Good afternoon and welcome to our webinar on digital quality measures. My name is Jeff Booth and I'm a principal with HMA. Our panel today consists of three national leaders in the digital quality measures space. First up, Ryan Howes. Ryan Howes is a principal with Levitt Partners, an HMA company. Ryan is a nationally recognized expert in digital health policy and interoperability. Based in Washington, D.C., he collaborates with the private sector, the White House, Congress, HHS, CMS, NCQA, and the VHA to advance digital quality measures and improve healthcare nationwide. We also have Daniela Simpson, who is a senior consultant at Wakely Consulting Group, also an HMA company with an expertise in healthcare analytics, digital transformation, and quality strategy. She leads Wakely's quality measurement group and has worked extensively with health plans, providers, and government programs to improve care quality and affordability through data-driven solutions. Next, we are pleased to have Dr. Eric Schneider join us today. Dr. Schneider is Executive Vice President for Quality Measurement and Research at the National Committee for Quality Assurance and an internationally known expert on healthcare quality. He has served as research faculty at Harvard Medical School and Harvard School of Public Health and practiced primary care internal medicine at Brigham and Women's Hospital. Our agenda for today is as follows. First, we're going to share a little bit about our leadership experience in the digital quality measures arena, followed by a discussion of the path forward to a full digital quality platform. Next, we will talk about the opportunity for health plans and providers to act now. And then we will close out with a discussion of the benefits of operating within a full digital quality model. Please feel free to submit questions in the chat as we move through this discussion today. We will try to address some of them as we go through the presentation, but we also have allotted 15 minutes at the end for Q&A. Thank you for joining us today. We will be sending the slides out to you after the webinar. And now I'd like to turn it over to Ryan.
Thanks, Jeff, and thanks everybody for joining us today. We're really excited to talk about this topic that we've been working on for quite a few years now with our partners at NCQA, and very excited to do that. So just a little bit about HMA if you don't know us. HMA is a family of companies, HMA standing for Health Management Associates. And three of those family of companies are on the phone today. I represent Levitt Partners. Levitt Partners is a national policy and advocacy firm that's focusing on interoperability and digital quality, but also all things related to healthcare policy. And so we work a lot with Congress and the administration on developing effective federal policy on a whole range of issues, ONC, CMS, FDA, all types of healthcare related issues. Wakely, which Daniela represents, is an analytics and consulting firm specifically focused on actuarial analysis and, as we mentioned, digital quality measurements. And HMA is obviously a trusted leader in strategic and operational consulting for state and local governments. One of the things that we do that's fairly unique at Levitt Partners that will help better understand what we're doing, why we're doing it, why we partner with these companies is that we have a business line called our alliance practices. It's called the Levitt Center for Alliances. And what we do is we bring together multi-sector stakeholders to try to solve really difficult issues in healthcare and hopefully develop effective federal policy. So I put a few of these on the screen here that we do. We run about 30 or 40 of these a year. The one that we've been known the most for in terms of digital health and interoperability is something called the Caring Alliance that's been around for almost 10 years now. Eric was at the founding, and so we were super appreciative when he was at the Commonwealth Fund. And the Caring Alliance is focused on getting consumers more digital access to their healthcare information, where, when, and how they want to achieve their goals. We've developed 3 different APIs, these FHIR APIs that are now actually in production all over the country and being used. And we have learned a lot about how FHIR APIs work in production. They are just starting to be a thing, and especially with business-to-business data exchange. If you don't know about FHIR APIs, you should know, and we would encourage you to find out more about that because certainly CMS and ONC and the VHA and all the other federal entities, again, regardless of the administration, are all in on FHIR. We are modernizing our entire healthcare data ecosystem. We've done other work in public health with the Helios Accelerator. We have the largest B2B fire initiative in the state of Utah. We've worked with NCQA on what's called the Digital Quality Implementers Community that's focused on modernizing and updating what's called the clinical quality language that actually allows for digital measures to run on top of. CQL is actually an open standard within HL7, and Eric's going to talk about digital quality measures in more detail. And we've done some work as well in housing data with HUD too, to develop a data model for housing related services. So it just gives you an idea of kind of some of the things we do, and we want to solve these really difficult issues as much as we can. With that, I'll turn it over to Eric for an introduction on NCQA and his portion of the presentation.
Great. Thank you very much, Ryan, and thank you, Jeff, for that kind introduction. It is truly a pleasure to be here with partners at HMA, Levitt Partners, Wakely. I'll just say a bit about NCQA. Many of you may be familiar with NCQA. 35 years, founded 35 years ago, to advance transparency and accountability in healthcare through accreditation, certification, and performance measurement, with the goal of improving the quality of health care for all of those living in the U.S. It was founded in 1990. We're an independent nonprofit, and we have a large variety of accreditation, certification, and recognition programs. Among the most widely used are their health plan accreditation and our patient-centered medical home recognition program. It also involves the pioneering of the healthcare effectiveness data and information set. I always have to think about it because when I first encountered it in the 1990s, it was called the Health Plan Employer Data and Information Set. And that's a widely used measurement tool. Over 70% or around 70% of the US population is actually enrolled in health plans that report measures using the HEDIS platform. So if we can move to the next slide. What I wanted to really drill in on today is the digital journey for NCQA, and specifically around digital quality measurement. So I've introduced HEDIS as this widely used tool. It actually, if we can jump back just for a second, it actually encompasses over 80 measures, measurable aspects of health and healthcare in 5 domains: the effectiveness of care, access and availability, the experience of care, and utilization and risk-adjusted utilization, as well as some health plan descriptive information. The focus of what I'll talk about today is primarily in the effectiveness of care area, which is where the clinical measures of process and outcome mostly reside. So a bit about the, if we go to the next slide, the digital phased approach, because we actually realized fairly early on in the early 2000s, I was actually co-chair of the Committee on Performance Measurement. And we realized that we were going to want at some point to move to a digital, fully digitally enabled environment. Most of the rest of the economy had done that and was leveraging computability. But healthcare is always a little different and a little bit of a laggard. But thanks to the efforts of Ryan and others on this call, we are making tremendous progress, especially in the last decade. So NCQA took up the charge of moving from the paper-based Volume 2, which lays out in narrative form the instruction set for how to collect data, measure, and report HEDIS, to a fully digital version that takes advantage of the digital capabilities of the modern data ecosystem. We introduced the digitization of the digital HEDIS measures in 2023, and we've been on a journey over the last few years to deliver those traditional Volume 2 measures through what we're calling our digital content services platform. That traditional data collection method is pretty persistent because a lot of programs across the country, there's a large variety of federal, state, and other programs that still use the traditional data collection approaches. And we're now in phase 2. We have actually built out, digitized all of the HEDIS quality measures at this point. We at least have Fire CQL versions. I'll say a bit more about that in a bit. And can now deliver the measures both through traditional volume 2, but also through this digital content services. We still have a few sticking points, and I'll get to those around how we make the complete transition. And what we've defined as sort of for probably 2027 to 2029 is the sort of cleaning up of those last remaining issues that I'll talk about in order to move from the traditional volume 2 to a fully digital enablement, where health plans are able to do reporting for HEDIS measure results end-to-end digital. And I'll say a bit about the hybrid method, which is one of those sticking points. And then finally, we aligned with CMS on the notion that we really want to sunset the traditional ways of doing reporting and go to a fully digitally enabled digital quality measurement framework. So this is the phases, the timeline that we have in mind as we're planning and designing our work. We're still looking closely at market maturity with our colleagues here to see how quickly we can move that agenda forward. And next slide. So let's dig into the weeds a little bit. Traditional HEDIS actually involved 3 methodologies. The first was the administrative method, where we're essentially using transactional claims data. That's enrollment claims and encounter data from billing records to construct the quality measures. And that's been the method starting from the 1990s. We introduced I think it was around the early 2000s, the hybrid methodology, recognizing that many of the clinical details needed to do effective quality measurement were hidden away in paper medical records. And but we couldn't ask people to sample thousands of medical records and retrieve the data. So instead, we came up with the hybrid methodology, which takes an administrative base population and then samples charts, samples a smaller number where the organization can go after those specific clinical data elements necessary to report a more clinically informative measure. We also had the survey methodology, which I won't say much about here because that is not yet primed to be changed in the new world. In 2015, though, if we can advance, we recognized the need to sort of help promote the pathway, the transition to digital data systems. And this is now in the post-high-tech era. Electronic health records are coming into play. Registries are maturing. Case management systems, health information exchange systems are maturing. And so we started to define what we call the electronic clinical data systems method for reporting. This is optional. It was introduced to allow willing health plans to leverage these other data sources, digital data sources, to report on HEDIS. So it's essentially a set of guidelines and rules for collecting and analyzing structured electronic data in a variety of formats, coming from a variety of sources for HEDIS quality measurement and HEDIS reporting. And the reason I bring that up is that was really has been our sort of transition strategy over the last 10 years. And if we go to the next slide, we are sort of in a position now where we're looking at 3 different methodologies in the current state: the administrative data method I mentioned, the hybrid method, and this ECDS method, which again was really to encourage timely and accurate quality reporting. In order to get to a full future state of entirely interoperable digital quality measures, we actually need these other methods to consolidate or go away, essentially, to where we're initially at least sunsetting or retiring the hybrid methodology, so that in the transition phase, we're relying on claims and billing data and this ECDS methodology, but then fairly quickly migrating beyond that to an all dQM future state. You take the next slide. And we've actually planned the timeline for the sunsetting of the hybrid methodology, because it turns out that measures vary in their level of complexity, in the availability of digital data, and in the ease with which health plans can actually make the transition from hybrid methodology to a full reporting method. A couple of the measures, breast cancer screening and a couple of others, have already been specified for hybrid. And this timeline just shows you the introduction of an ECDS version for each of these measures in each measure year. And then the dots represent the removal of the hybrid methodology, so that they will be available only in digital format going forward. And you can see, obviously it varies as to when we sunset those. We are deliberately leaving at least 1 year for parallel reporting and testing, not necessarily for everyone in the field, but just for our own purposes to understand whether we need to reset benchmarks. We've already done some analysis that shows some measures where it doesn't make a big difference, whether you're reporting using the ECDS method or the hybrid method, and some others, though, where it does. So an example is lead screening in children. We've actually now just approved conversion of that. It turns out it doesn't, what we call the hybrid lift, the ability to report a higher result based on the moving to the hybrid methodology is small. For some others, like controlling blood pressure, it's larger, so we're taking more time with those. But ultimately, the point is to remove the hybrid methodology by 2029, so we're not still requiring that burdensome approach to sampling and data collection. So the end state we're aiming for, and I think everyone is aligned on this from what I can tell. I don't think there's anyone out there who said, no, we should never do digital quality measures. But what are they? What are we saying? What do we mean when we say digital quality measures? And the first characteristic is that they rely on standards-based data exchange. So specifically, fast healthcare interoperability resources. And the notion is that the FHIR standard as the exchange standard allows for the interoperability necessary to, at low cost, exchange data, collect data, exchange it, and aggregate it for measure calculation. The second feature is that it's written in a machine interpretable language. So our measures today, we can rely to some extent on clinical quality language, but the work of the last 2 years has been to see where the gaps are in the CQL language, which is a relatively new language in computing. It's only been around about a decade. And there are characteristics of the measures, specifications, logic in the measures that we need to make sure can be expressed in CQL consistently for the machines to be able to read it as well as humans. And then the third is to incorporate the data concepts and terms, what we call the value sets that are required to calculate the measure. So if you have the exchange format in standardized form for the input data, the language for calculating the measures, and the value sets that are the substrate that the measures are being calculated off of, then you get easier deployment into health IT systems. You get a reduction in the amount of reinterpretation, interpretation, recoding that can introduce human error. And we get, we think, standardized use across many types of different organizations. If they can map their data to FHIR, they can report digital quality measures in this new world. So I think that's all I was going to share, and I'll hand it now to, I believe, Daniela.
Actually, I'm next, Eric. But
sorry, I'll hand it to you, Ryan.
That's okay. So let me just ask you a question, Eric, because this is for really the benefit of everybody here. So you're telling me NCQA is really moving to fire? Like this is a real thing? Like you really want to do this and you're not going to change your mind, right? This is, can you just explain to people like this is a real thing? I want to make sure folks really have clearly understood that idea.
Yeah, there's really no debate really about the future as far as using interoperable data for quality measurement and reporting. FHIR is the standard. Has the flexibility and the specificity and the range of definitions that are necessary to do this effectively. There are obviously other standards out there, but our theory of the case is that those standards, those data can be mapped to FHIR. There are translators, there is every opportunity to put the data in FHIR. So even if you don't collect it as FHIR data, it could be mapped and translated. And we believe that that's ultimately the future. Just as in other industries, data standardization has allowed a tremendous flexibility. We think that's the future here. And I'll just add that we have specified all the measures now as FHIR CQL, so that they're there, they exist today. It's just a question of how quickly they can be taken up. We also have been testing them in test beds, which maybe you've already talked about some of those, but we're testing them and showing that they can work in a diverse set of data systems.
So this isn't really a hypothetical. This is like something that's actually happening right now. As you mentioned, we are actively have a test community that is testing all of the HEDIS measures as we speak, right? And
Right.
running it on CQL and doing this. So even that timeline you showed of 2030, the idea is that folks could take advantage of this today. Like that, this is something. I guess the other really important point is both payers with their claim system, because CMS required this many years ago, and health systems with their EHR, both of them have the what we call the regulated FHIR APIs, right? The clinical data and the claims data to run these digital quality measures today. It's not that this, again, is something that you have to wish for. They, through what's called the patient access API, they have the clinical data that they need, the US CDI, US core data on the FHIR API on their EHR. And on the claims side, they have the claims data, which is the Karen IG for Blue Button, which is the claims data model that you guys need for digital quality measurement. So I guess the point here is that we're reusing existing infrastructure. Is that fair to say?
Absolutely. So when I first arrived at NCQA 3.5 years ago in the current role, having had this long history with NCQA and seen it over many years, I thought that when we did the first test to say, what standards do we have already, and do what percent of our measures could be run using those standards today? I was shocked that actually 80 to 90% of the work had already been done. The standards were already there. The effort over the last couple of years has been to close those gaps, but there is really nothing from a technical standpoint standing in the way. It's really the readiness of participants across healthcare to make the move into FHIR and a data exchange and those standards.
That's awesome. Thank you, Eric. I just want to triple underline that point. We can start today. This is not some future thing. It's something we can start today. And I'll just add this in this slide that we have on the screen here. As of 2027, there's a CMS rule called the CMS 0057 rule, the prior authorization interoperability rule, that requires business to business data exchange, so payer to provider data exchange, including clinical data, claims data, et cetera, of these same what we call regulated APIs. So again, the US CDI API and the Karen IG for Blue Button API. Those are both required to be sent to everyone, payers, providers, and patients by January 1st of 2027. So within the next 18 months, and I've talked to all the major payers, and they're going to be ready to test in the fall on prior authorization and all of the things that are required by 2027. So the payers are ready to go. I haven't obviously talked to all the health systems, but I know many of their EHRs already have this functionality effectively available. You have a situation where you can now be able to exchange data not only with NCQA, but then also with each other using this FHIR API infrastructure. So I think if we don't get anything else from this webinar, just know that talk to your EHR vendor or your health plan. If you're a health plan, talk to your claims vendor or others related, or your vendor that you're using for a Fire API gateway. Talk to them about this need to also be able to implement digital quality measures. It's something that is literally ready to go. And as I mentioned, as Eric mentioned, it's not a hypothetical use case. It's really something ready. So I didn't want people to get lost in the timeline before, Eric. I wanted to make sure people knew that it's ready. So awesome. So all of these reasons as to really why to act now. And there is obviously the financial penalties as well. But I guess what I would say is that it provides such a burden lifter for all of the health plans and providers that are out there in terms of ensuring that this can actually be done digitally rather than doing it in more of, as you mentioned earlier, Eric, the manual process that we've had before. That's, I think, the big takeaway on this, and it provides some opportunity. I would also say very quickly is Eric and team and Danielle and I have all been working as well very closely with CMS too, and they're very much on fire. In fact, if you look at the IPPS rule, if you look at the CMS RFI that came out, they are all in on fire, and they are all in on digital quality measures as well. In fact, just the payment rule that came out on Monday, there's a whole section in there about digital quality measures. So I want to reemphasize to this group, the time to move is now. It's not necessarily later. It's definitely something we need to do immediately. So with that, Danielle is going to talk about what do we need to do when we move? What does this actually start to look like? Go ahead, Danielle.
Thanks, Ryan. So what we see on this slide here is kind of summarizing a lot of the things that Eric already mentioned. So we have a side-by-side comparison of the current traditional model and the future digital model. And for those that are more methodologically oriented over there in the audience, they need to go step by step. What does this mean in this world, and what is going to mean in the future digital world? I'm going to highlight the biggest changes in this. Specification delivery is kind of at the top, and that sets the stage and it cascades down. But the way that the specifications are delivered today, many of you know, we get the static document, the PDM, the beloved volume 2, and we interpret the heck of it, and we manually implement it. That's going away. We saw a preview what some of that will look like, but in 2030, we're gonna see, and we're gonna get an executable code packages that NCK calls digital content services, or DSS. And these are really not just machine readable, but they're also ready to run. So you can execute them. So that makes all the necessary steps to get from that PDF to an actual measure results much more automated, much more standardized, much faster, and really avoids all these unintended variances that inherently happens when things are executed and implemented multiple times. So the biggest thing is, in the future, you should be able to get your measure specifications and measure run much easier, much sooner in the future, because that will mean that your vendor now just has to validate the execution of that content, not code the entire volume 2 in specifications, and before they can share it with their clients. Ryan already talked a lot about the data model. It's gonna be synchronized. We're gonna have a common language. We now have clinical data. We have claims data. They come in different format. It's really can get messy to integrate them. Fire is here to help us solve that problem. We have an implementation guide. We mentioned the carrying blue button on the claim side. We also have something called US Core on the provider side of things. This implementation guide conforms the data to the right standards. So when the data comes in for different use cases, including dQMs, now we know that it's actually usable, and it has all the information, and the information there is structured the way that it needs to be structured in order for the measures to run. The reporting method is a big change. We know that hybrid is going away. It's a relief, and also causes a lot of anxiety, as we know. Anxiety because depending really how big your hybrid lift is, and we're going to talk about that more later. But on the positive side of things, if that's a heavy duty 3 months process that every organization goes from February to May, and I know a lot of them will be happy to hear that we have a much better, more standardized way to get the data without really having to go to the DENSTAT for every year as we have done in the past. So with this in mind, I would actually encourage everybody to take a look at this slide and kind of decide which side of the slide your organization is aligned with today. And then this is more importantly, what is the timeline that you will need to get from this current traditional to the actual future digital, because every journey is going to look different, and everybody based on the starting point will actually need a different timeline and different plan to get there.
Daniela, we had a question come in. By the way, I'm trying to answer the questions as they come in, but if they're too difficult, then I pitch them to Eric and Daniela. One of the questions was, could you say more about what full population reporting means under the reporting method? Does that mean full denominator versus a sample
Correct.
or something broader? How is the denominator identified in the future digital scenario? You want to take a shot and Eric can chime in?
Yes. So that's exactly what it means. It means that we are no longer be reporting the rates on a sample population. So currently the way for the hybrid measures, we run the full population, and because as Eric mentioned, it's really not realistic to expect to go and get the medical record review manually abstracted, or it wasn't realistic in the past. We the methodology allowed to sample like 411 members, and sometimes that sample was actually even reduced further down based on how well you did on your in your prior year or in your administrative rate. So that's going away. So right now, for example, if your population for diabetes, it's 411 and your full population is 10,000, now you have to get the data for the 10,000 members.
Got it. Eric, anything you'd add?
Yeah, I would just add, full population didn't mean, all of the people in the US for sure. But it is what Daniela described. I'd also, I think there was a point in there about the denominator, how denominators will be specified in the future. Right now, they're claims-based denominators. We are actually actively exploring, as we're expanding the number of data sets available, what's the way of doing that in a reliable way, so that we can do apples to apples comparisons and make sure that if we allow, for example, electronic health record problem list to be part of the specification, that we know we're getting similar response across organizations. So there's some details to be worked out there, but then the notion is exactly what Daniela said. We want to be able to define the denominator broadly, the people who are being impacted by the care that's being delivered. Right now, sometimes the denominators get narrowed through exclusion criteria to the point where you may only be reporting on half of the people who with a condition like blood pressure. So that's really the aim, is to increase or broaden the denominators, but also to remove this hybrid methodology and the notion of smaller samples within those denominators.
Awesome. And we love the questions coming in as we go. So this is very interactive. This is great. CQL engine is more geared toward plans, providers, and other healthcare organizations, right? Yes. Are you aware of any state Medicaid agencies leveraging ECDS? Typically, Medicaid agencies don't have access to patient clinical data. Eric, you want to take that one?
Yeah, I think that's also the breadth of the definition of ECDS. I think some state agencies are leveraging their immunization registries, for example, which is part of an ECDS specification. But I think the point there is there's a set of needs around data sources from Medicaid programs that differs from and reporting quality measures for Medicaid that may differ from what we're observing in other parts of the health data ecosystem. And we're also working toward, what does that look like? How do we adapt the system? The fundamental architecture is going to be the same. It's APIs accessing data. It's just a question of, okay, what are the rules? If Medicaid agencies don't have that access, who has that access? Is it a vendor? Is it some other party that can then, the queries can be directed to get the necessary data for the reporting?
Got it. And honestly, Medicaid agencies also are going to be able to access the clinical data anyway because of the 2027 rule, because they're part of the Medicaid fee-for-service side. So they could actually ask the Medicaid providers to send them the USCDI information. The question is, how would they actually have the CQL in order to run the measures? They'd either build it themselves or they'd actually get a vendor to do that. So there's I guess multiple options, right, to make that happen. Danielle, anything you'd add on that?
Nope,
Okay,
I
let's
think you
keep
covered it.
going forward then. Whoops. Sorry, having a little bit of, there we go. Slide
No,
issue. Go ahead.
so zooming out a little bit, what do we envision? How is this going to work? Taking a look into the future 2030, the new data and technology stack. And for those who have been working with HIDIS, they may recognize the data flow kind of stays the same, but there are a lot of different things that's going to make this much easier. So the first thing that, kind of looking at the slide, is we don't see currently that we have now is those training wheels on the HIDIS engine, which is now a dQM engine. We do not have the medical record review. We now have just the dQM engine that can enable all the data once they're processed, validated, and summarized, be sent to either NCQA for reporting and accountability purposes and CMS, but also more importantly, you can run your measures as often as you need, not once a month or once a year like we are doing it today, and sending it back to the record, to the system of record. So those are now actionable and inform either the member or the outreach or the provider care at the point of service there. So this loop becomes super important for multiple purposes. It really just gives you results much faster. It also kind of helps you obviously make difference, make not just capture your data gaps, but really close your care gaps. And the other things that we've been talking about a lot is that we are using regulated data. So this is the same data model that you have implemented or you need to implement across the spectrum to be compliant with CMS regulations. So this is not one use case only effort. So you can leverage all the experiences from the data architecture and just make sure it's really layer it with what makes sense is for the dQM, and kind of moving away just from what's regulated and what's mandated. I know many health plans are in value-based contracting with providers. Data sharing here, it's an impediment. We know this. I know it slows things down and it does not really work as easy it should be. Well, you can use the same architecture to exchange data when you're with your value-based partners. There's no need to stick with the current claims and outdated processes that really are just way too sometimes are really too late to make a difference. We do get more sources. Like one of the biggest opportunities here is that we're going to get a much better picture of the members. So yes, we have claims, but we're going to have the EHR data for all the members, or ability to get EHR data, clinical data for all the members. You can tap into sources that maybe were not part of the current environment, like your disease management systems, your case management system, your patient portals, health apps, anything that has a FHIR-based data that we can validate that it's really trusted data. And when it comes to trusted data, peak is kind of, you see a peaky kind of green diagram there that basically indicates that we are going to evaluate the fitness of the data for quality measurement. So we use quality measurement, we turn those into national benchmarks, we compare, we pay some lines of business based on these results. So it's critical that we continue to have trust in the data. And so the PIC is giving us a nice open source digital way to validate the data. And it's really The advantage of Pika is really that it's happening on the fly, right? So you get the data and the validation happening before you have it loaded in your own system, and you identify something is wrong. Then you have to send back to the source, and this just kind of slow things down. Piki is a framework that can help you adjust and create this feedback loop, so the data is really evaluated and scored before it's loaded into the dQM engine, and it's flexible enough again to be implemented at all different pipelines, including data that you're maybe getting from clinical registries or data aggregators and so forth. So there's a lot of advantages to make this process much smoother, to make this process kind of work and help your use cases, not just for reporting HIDIS, not just for value-based programming, but it's also for disease management, for population health, for analytics, predictive modeling. So now you're going to have all these great insights that you can use at the same time with claims and other data elements to manage your population and lower your risk and overall cost of care more efficiently.
Daniela, let me just really quickly mention, folks may have not heard of Piki, so I just want to make sure we understand what that is. If you go to pikiframework.org, P-I-Q-I framework.org, you can learn all about it. Think about this as an objective way to measure the quality of the data no matter where it comes from. So what we're doing, we're working with Eric's team at NCQA to ensure that this could be an electronic way to do PSV. So the combination of Piki and the combination of some of the electronic ways that they're thinking about PSV and DAV in the future, this is a really great opportunity where we can use an open standard as well as the electronic ways that NCQA is thinking about PSV in the future. How does those two things work together so we can more electronically validate the data at the source? I think that's point number one. Point number two is like in the chat. Thanks for all the questions. Jing, just so you know, you're right. Fee-for-service claims data is relatively timely compared to managed care encounter data, but it doesn't necessarily mean that that needs to be the case all the time. The purpose of these APIs is for you to get real-time information. That's the point. You don't have to wait. You can ask your Medicaid managed care vendors to send you those APIs every day, every night, every time that there is a claim that's actually been paid for. That's the benefit of using an API ecosystem, is that that can happen at scale. As Charles says the same thing. They're working with 19 MCOs. Shouldn't matter. All the MCOs should be able to send you the exact same API and send it to you on a real-time basis, so you're not waiting for this stuff until the cows come home, so to speak. Like that is not something you need to be waiting for. You can ask for that as a state, you have to have the ability to accept those APIs into your environment. You can get an API vendor to help you do that, an API gateway, and I would strongly encourage you to do that. But then when you get the clinical and claims data in real time, you can use it for all kinds of use cases, public health data reporting, right? As we talked about digital quality measures, there's all kinds of ways you can reuse it. I just don't want folks to go away thinking, oh, that's just the way it's going to be forever. It's actually changing that significantly. The other question I'll announce is the Piki framework, P-I-Q-I framework.org. I'll put it as well in the chat. Eric, you came off mute. Go ahead. You were going to say something.
Yeah, just wanted to give a shout out to the comment about data coming from health information exchanges. I think that's actually a piece of the architecture that's going to enable the aggregators. It's in the dotted box here, but that architecture actually takes a lot of the work away from individual provider organizations, health plans, because once you get it into the exchange, a lot of these data quality checks and other things could be happening in real time based on what Ryan was describing and other efforts that are underway to monitor, improve, and create the incentives for improving data quality.
Awesome. Thank you. Go ahead, Danielle.
Yeah, thanks, Ryan. So how do we get there? How do we get from the current 2025 kind of world to the 2030? And as I mentioned before, it's going to depend on where you are on that first slide we showed. are you more on the left side or the right side of the spectrum? But certain key milestone or certain checkpoints actually apply and applicable to most of you. 2025 is already underway, and I've seen some big changes in the industry and just real excitement about digital quality measurement, which is really exciting to see. We've seen some first roadmaps being developed, a lot of questions being asked, and if you are not doing that right now, that probably something you should get going as sooner rather than later. But if you are to if you're starting to evaluate your journey, your digital journey, the first thing you kind of want to see is like, when do I want to change? When do I want to make this transition? Because as Ryan and Eric mentioned, there are just a lot of reasons why you may want to not just start but complete sooner. So 2030 might be the target here. Is that can you start can you transition earlier than that? That's really what you should be asking yourself right now, and then that will depend on your internal capability. It will also depend on your vendor capability, on your partners, how you're going to get this data, how you're going to connect to all of your current vendors. It's just a lot of ways of, like, we got a question saying, well, about the latency. A lot of these things is really reimagining, not just lift and shift. If you're just going to lift and shift what you have today, you're really not doing yourself a service. What we are thinking was, how can we do this better? We also have dQM vendors on the market. We started this 2025. We're going to have even more 2026. So everybody, by the end of this year and next year, should have probably had a roadmap, outlined, their vendor assessed, and probably start some kind of a proof of concept on, hey, what are my digital results are going to be. The next year are more of an implementation years. I highlighted 2027 for multiple reasons. Ryan already mentioned a lot of those reasons. He kind of tends to steal my thunder there. But 2027, there are big things happening. We have the new advancing interoperability and prioritization role. And prioritization is kind of stealing the show there in the story, but there are a number of APIs there that are super important for HEDIS. Pair-to-pair is critical. Pair-to-pair can help you close the hybrid lift for five of the measures that are currently just right now being sunsetted from hybrid into ECDS. So if you're not thinking about leveraging those to help you with your clinical data acquisition, you may want to go ahead and talk to your interoperability friends and see how you can go about it. The other big thing I want to mention here is, if you remember Eric's slide with how the hybrid measures are getting sunsetted, well, in 2027, we're going to see a couple of measures that currently are not expressed in ECDS, the GSD being one of them. We're gonna have that version. So right now in 2026, you don't have to account for any hybrid results, any hybrid nuances when you start with your parallel testing. So it's really important to start focusing more on the digital measurement and the digital specification, and the environment will actually support you and be able to do so. 2028, 2029 is expand, scale, enhance, refine, really what you have already implemented, what you have already started to implement 2026. How can I do it better? How can I do it faster? Who else can help me on the journey? And for those who actually have identified your hybrid lift and have started to see going down, you probably might be a right time to start doing some much more serious parallel testing efforts. So when you're in 2030, you're just kicking off the new season where you can see even on the slide, like your tasks, your activities are going to go down. You're going to start focusing more on automating, monitoring, and improving. If you have already passed parallel testing, and we should probably mention that every health plan who is planning to transition to digital measurement will need to go through a parallel testing of their traditional results to their digital measurement results. It's that can happen anytime between the now and 2030, depending on where you are, and when you feel ready to make that change, when you have all of your vendors and partners in place for that. What it's going to take 1 year of a measure of data. So if 2028 is your measurement year, in 2029, when you submit your traditional rates, you also need to submit your digital rates. Rates are reconciled, and then the following year you are allowed to report digital measures and results only. And
Yeah.
it's we're into the future, 2030, we're into the future.
Well, so Daniela, what you've done is you said there's a lot to do, and there's
a lot
a
to
good
do.
amount to do. So I guess my point here is that I think what you're saying is this idea that it's both a technical issue and it's a business issue. You mentioned the fact that don't lift and shift, meaning you got to redefine all of your business processes related to quality measurement reporting. You're not just lifting and shifting something, it's going to really redefine how you do this work. And what that means is you need to start asking questions now, as in how are we going to send and receive API information, right? What are we going to do for that? How are we going to be able to run these measures? Do we need to go get a CQL vendor, for example, to make sure we can do that? Or are we going to build it ourselves or do something else or have our HR claim system do it? What are we going to do to run these measures themselves? How do I get engaged with NCQA to be able to run the digital content services too? And how do we start testing as part of these beta clients? And then what does this look like overall in terms of my reporting and my workflow? Like, what does that look like from an actuarial perspective? And how does this actually measure with HEDIS and STARS and all the other things you've got to do? There's all these questions we could ask now that allows us to put us in a position to be successful in the future. Is that fair?
That's very fair. This is a great model. I think the sooner we start taking advantage of it, it's going to go through this whole real life testing, and we're going to learn more. We're going to get an opportunity to make it even better. I think the feedback from the health plans and the providers is super important as we start this journey, because everybody collectively going to learn more and make this work better for everyone.
Awesome. Awesome. I know we've got about 7 minutes left. So I think this is our last slide. I hope you understand the benefits. I hope that is very clear, that these benefits of moving to more of a digital quality measurement reporting platform are substantial. I hope you've heard today that NCQA is fully committed, as Eric mentioned, to doing this and moving toward this model. I hope that you have enough internal political help and support and senior support for this project, that it gets prioritized. We recognize there's a million priorities in healthcare, and there's a lot of things that are happening right now. But certainly from the stand of burden reduction and potentially wasteful costs that are currently now there, you can start to focus on the things you really want to focus on, which is actually the reporting of those quality measures, what they mean and how you close care gaps and how do you do all of that fun stuff that you've wanted to do to improve quality overall. That's really kind of our message today, is what does that actually look like at scale? So here's some of our contact information if you'd like it. I know we're at the last about 6 minutes left to go. You've done a great job as an audience to provide us some questions, and we've tried to answer those either in written or verbal form as part of this webinar. We'd be happy to answer any additional questions that you've got. Feel free to put it in the Q&A. Eric, while they're thinking of questions in the last 7 minutes that we've got left, slides are going to be shared. Yes, we did answer that earlier. They're going to be emailed to you with a link to this webinar, and they're also going to be on our HMA site. Give us about a week or less to do that, and everybody will receive it who attended the webinar today. Eric, one of the things that we're working on together is this concept of what we call the Digital Quality Implementers Community, which is a group that is focusing on what I would consider maturing the CQL standards so that it could run these measures. And one of the great things that we've been in the last 2 years as we've been working on that project together is that the CQL standard has matured so much that now we can really run all of these measures, right, digitally. And so it's happening now. What has been some of the reactions you've had and from folks, from people that are running the measures, kind of the early adopters? What kind of feedback have you heard from them?
Yeah, so it's been a great journey of discovery. Like any new technology, there are kinks to be worked out, and we've been working through those very aggressively in this past year, or what's the first half of this year. We've learned a lot. We've actually fed back information to the community. The community comes back with suggestions and fixes, and so it's been a really fruitful collaboration and community. And so if people want to be part of that, we'd be excited. We're always excited to have people be part of that community. I also just wanted to underscore something that you brought up a couple times, Ryan, about the other uses for this data. And for CQL, actually, CQL as a clinical quality language is powerful for a lot of different uses. I can say as a practicing clinician, the data that you use or need for quality measurement are the data that you often need to guide care and drive clinical decision support. So if you're developing this infrastructure, you want to be thinking about all those use cases, not just the quality measurement use case. I shouldn't say that as the NCQA guy, but I have to say it because it's the value is actually well beyond being able to report digital quality measures.
Yeah, that's a really great point. Well, I know we're at time. We so appreciate everybody for joining us today. Thank you for the time. Thank you, Jeff, Daniela, Eric, for all of your time. We'll allow you guys to transition to your next call. And again, thanks everybody. If you have any questions, please reach out. We'd be happy to respond. Thanks, everyone.
Thank you, Ryan.